and we are good. So Rita, the floor is yours and we are ready to go.
Good morning. Good morning. I am so happy to introduce Dr. Cameron Wolfe. He's the HIV infectious disease doctor at Duke University. I met Dr. Wolfe 10 plus years ago when he was just an intern. Since then, he's had his hand in a marriage with two wonderful sons, transplant in HIV positive people, and now he's into COVID. And so I hope that you all enjoyed this presentation that he'll do this morning, and please have lots of questions for him because he's ready to answer. All right, Dr. Wolfe, it's on you.
All right, Rita, I appreciate that. Hey, thank you for everyone for joining. I'll try and, this is going to be a bit of a cook's tour of things in HIV specifically. Matt, as I turn my screen on, I won't be able to keep admitting people, so I'll leave that to you. I'll try and keep a look on your chat function if folks want to ask questions, or I think I can probably do both. So bear with me while I pull this up. So like Rita said, my role here at Duke is a few different things. I'm primarily these days a transplant doc, but I still keep up my HIV practice and often have been involved in the crossover of those two. But also my third hat, which is quiet 9 years out of 10 and frenetic, the other one is to deal with outbreak situations. So I kind of wanted to talk a little bit about COVID, give you some data on what we know about HIV and COVID, and then sort of, and really just allow plenty of time for questions as we go. So, I'm going to start with a horrendously busy slide by intention, because this was my first, I remember back December the 30th, literally the first day that I ran into this last year. We get these emails periodically that come through on ID listservs about different sort of clusters and issues that are popping up around the world, and there's lots of different things. And I remember reading this one that said, undiagnosed pneumonia occurring in China, we need some information and some help. And it went over the space of 3 days on this little quiet private email chat from, hey, there's 4 cases here, to, hey, we've got 27, hey, we think we've got a whole bunch and we're going to close down a food market and something's going on. And I think suffice to say, if I could put a dollar at that point on, would we be here 9 months later, sort of recovering from a worldwide pandemic, I don't think I would have predicted this. I don't think anyone else would have either. And sort of along the way, we've gone through really a bunch of different waves of this, haven't we? We went through a phase when the idea of hopping on a cruise ship suddenly became ridiculously crazy for anyone. And on the picture on the left was our sort of first encounter with a person in North Carolina, where we really didn't know what to anticipate, and in fact drove to the airport to head out on the tarmac to meet someone who we knew was flying in from China with symptoms. Again, quite a different way, different place than where we are now. And I'm sure many of you, have sort of since realized that, in fact, this pandemic is going to continue with us for many months, and we've adjusted in many ways that I'll talk about as we move through here. So first things first, I wanted to start with sort of where North Carolina is. And I think that the really good thing to say is the picture on the left represents patients admitted to Duke Hospital, so our sort of immediate hit as a result of all of this. The numbers on the left, hospitalizations in North Carolina. And there's a couple of things that I want to sort of highlight here. The first is that there's lots of different data points that people can find in the news and in the community to talk about all manner of different challenges, and just reading into data. And I would caution you that there's so many of those data points, some of which you just clear out of the way and think about what are things that are really important. And to me, things that are important are hospitalizations. There's no way of fudging that based on our testing, based on who's getting sick. Currently, if you're still turning up to a hospital with COVID, it's a really good representation of how much COVID must be in a particular community. And if you look here, the peak of that yellow line for the Duke admissions overall, about just under 100, was occurring in the middle of July. That was kind of our peak in North Carolina, at least in terms of severity. And similarly, that was a little bit later in North Carolina as a whole when we peaked at over 1,300 people in hospitals. Like that really is a horrific number when you think about it. More than 1,000 people admitted with viral pneumonia. And that number has subsided a little bit. We're still sitting around 850, I think, at the moment. So, still a very large burden, even though this thing kind of feels like we've faded a little bit in the last couple of weeks. And if people want to go on and really sort of start thinking about like, hey, maybe I can start actually doing some activities or start doing a few like church services or attending some gatherings, I challenge you to go to this little website. You can Google it through the Georgia Tech COVID event risk assessment. And it literally lets you go on, the data is updated, I think, weekly that's behind it. And you can plug in your county and say, right, I want to have an event of size X. And it will give you a statistic of how likely it is that there's someone in that audience in your event that will have COVID. So for example, here in our group, we have 17 people, it looks like at the moment, plus a few others of us speaking. So let's guesstimate 25. And if you were to be in Durham County at the moment hosting a 25-person gathering in person, 40% chance that someone in that room has COVID still. Whether they know it or not, it's the other challenge. And so I've used this quite a lot to then sort of talk to different church groups, different gatherings, different protests, to sort of say, look, hey, here's the reality still about where your numbers are. You get up to 100 people or 500 people, you can see the percentage likelihood of someone there being positive, and infectious obviously jumps up much more. We know a lot about the illness that we probably didn't know 6 months ago. And let me sort of step through some of this because I think it's important to really wrap your head around it. The first and the big overall summary, if you take away nothing else, is that it is a very slow illness compared to, say, flu. We run typically with influenza about a 1 to 2 to 3 day incubation period when you're exposed to when you start getting sick. And generally, before you get sick, you can be infectious to those around you for maybe about 12 hours. You've got to really stretch that a lot when it comes to COVID. So, for example, the average length of time between when I get exposed to someone and when I may become symptomatic is 5 to 6 days. And there's probably 48 hours before I know that I'm sick, if I in fact feel sick at all, where I can be infectious to others. So that whole timeline is stretched, and people often forget about who they ran into 5 days ago to necessarily know where they might have been exposed. And yet there's often long periods of time when they are infectious and don't have many symptoms. You think of what you do when you have flu. What do? You feel sick, you feel lousy, and so you stay home, you stay out of the way of people. If you don't feel that bad with COVID, as is the case for most adults, you don't do the things that typically would allow you to avoid lots of people around you. Generally speaking, once someone's sick, we think they're infectious for at least 10 days, for about 10 days. That's true of a mild illness for people who have much more severe illness, like those folks who end up in the hospital, or for people who are meaningfully immune suppressed, that can sort of stretch out to about 20 days typically. Again, much longer than what you would think for the average person dealing with flu. We know this is a droplet spread illness. And to separate that from some other viruses of note, it's not felt to be an airborne illness. And so that's really important. So an airborne illness, this entire room around me would automatically be exposed to the air that I breathe, and everyone in the room is exposed. And so that's true for conditions like measles. It's true for conditions like chickenpox. Here is very different. Here is the particles that I create with COVID are heavy enough that they sink to the ground pretty quickly. And so we typically think of about a 6 feet distance between me and someone else for me to get them infected. Now the particles can survive on surfaces. So if I cough, sneeze, breathe heavy, those particles will fall to the table and I can still contract them that way. But it's a close proximity thing. So when we talk about ways of mitigating COVID, we can do it through distancing, we can do it through masking. The other thing to say is that, we've watched the world do some pretty crazy things in the last 6 months with wide variability in how successful different countries have been. And, you know, I'd be kidding you to say the US has been particularly successful so far at keeping this under control. We have had our struggles, but we're not the only ones. So if you look, for example, at that red line, the red line is what's happening in Spain leading up until a couple of weeks ago. And the same is now happening again in France, where they're seeing quite significant secondary surges. And I think the take-home message for that for us needs to be, yes, we've become better at dealing with this in the United States. Yes, those numbers in North Carolina are falling. But equally, yes, they can go back up if we don't keep up a lot of hard work in terms of distancing and masking when we need to. And there's plenty of things that we don't know yet. Like, what does this mean when we start bringing colleges back, for example? So far for us, we've done okay, but UNC and NC State, for example, have really struggled within a sort of fraternity environment or a college environment. What does it mean for sport? Is that realistic for us this year? It may not be. What does it mean for voting? You know, we have a pretty decent day coming up somewhere in November where there's going to be large crowds of people presumably coming out to try and vote, and a lot of rallies between now and then. How does this virus deal with that? It sure doesn't care. Whatever way you're congregated is going to be significant. So when we've looked worldwide, we understand a lot more about now how people present with COVID. So if you look at the top line, this is symptoms, and the dots represent sort of proportions of people with different symptoms. So as you can see, the majority of people, in fact, about 15% would say, look, I've had some history of breathlessness, fever, and malaise, so fatigue. Occasionally cough, but it's usually dry. It's not usually a productive cough for COVID. You can see different sort of mixtures of all of those. But the key is that almost all of the people have more than one symptom if they're going to be symptomatic. Of those who make it to hospital, the other significant part here is that we understand a lot more about their comorbidities. And so age, overwhelmingly the biggest thing. So irrespective of all else, folks over the age of 65 and particularly over the age of 75 are represented heavily in mortality data and those who need admissions. Outside of that, it tends to be the usual things similar to flu: poorly controlled diabetes, obesity, chronic heart disease, chronic lung disease, hypertension. And so that sort of fits this somewhere as an illness that's roughly, you know, not quite as fatal as some of those issues that you see here listed, but also a little more easy to spread. And so it kind of has hit that perfect little niche where it's a virus that can remain quiet in lots of people. There's about 35 to 50% of people will be asymptomatic when they have their COVID. So they can still spread it, but they don't know that they're sick. A mortality that is markedly higher than flu, and an average number of people that I can infect that's actually much greater than flu, although less than some other things that we're usually really scared of, like polio. So it kind of hits that perfect margin where it doesn't make you so sick that you'll die out, which is what happens with, say, Ebola or ominous things like that, but very easily transmissible and still affects a lot of people, as we saw from surges in New York and Italy and these sorts of places. So when it comes to HIV, I'll be honest, we don't know everything perfectly yet. Generally speaking, I think if you want to take home a couple of different messages, it does seem that, similar to most things these days with HIV, the better your viral control, the better your CD4 count, the less likely this will be to pose you any different risk than it would for anyone else. And in fact, the COVID risk in general for people who I speak to in my clinic is probably far more proportional to their age and their comorbidities. So again, weight, diabetes, heart and lung disease, than it ever is to do with their T cell count, because for the most part, we all do a better job about that. There's a few trials that have sort of, and they're not even trials, they're gatherings of people who we've been able to look at to sort of say, well, look, what does HIV add to the picture here? And one that was, I think, significant that was collected and presented at the World AIDS meeting recently was a group of they essentially cohorted in the southern part of South Africa, all of the folk who they knew to be COVID positive, and HIV patients made up about 17% of that group. That may seem a lot, but remember the baseline frequency of HIV in South Africa is higher. And they did see that a couple of things stood out. Firstly, of those patients who passed away, the age of the HIV infected people was much younger. And there certainly was a significant trend towards having higher mortality if your viral load or your CD4 count was poorly controlled. I think, speaking to what I said earlier, is that if you do a good job of taking your HIV meds, this doesn't really pose you much more of an issue than anything else. What's confounding in that is that, of course, a lot of patients in South Africa also with HIV have other problems. So they have TB, they have higher rates of blood pressure control, they're often a little more socially disconnected. So it's probably not just the HIV that drives the problem. We've also learned a lot about what we can do. You know, it's actually not that hard to figure out how to break the cycles here. I feel like as a community, we sort of hit mid-July and realized that we can actually do a lot of these things very effectively. You know, the first is, it took us months to convince people that a simple mask can actually be really effective. And yet I feel like we've finally tipped a threshold point where now so many individuals around the community wear masks as a sort of a standard part of going out that it's almost become a little surprising when you see someone who doesn't. And that's been a big phase change for us, but it will have helped. The other thing is, you know, I would look at this sort of group and say, look, hey, of all of the groups who really have a good sort of educational capacity within their community, you guys actually are in a pretty good position to sort of really lead by example. We've learned about a bucket of other things that are completely unrelated to COVID, but have been forced upon us. And I kind of want to paint you a few things. We've learned about our supply chains. So for example, many of the infection control things that we use in hospitals, for example, high-grade masks, are all manufactured in China. And our potential to have good supply chains of those when suddenly everyone wanted them went up in smoke. So we had to figure out ways of cleaning them. And so in actual fact, one of the things that Duke was able to really lead the way with was a method. You can see the thing that sort of looks like a robot off on the far left of the screen is in fact a special kind of fumigator that essentially we can fill the room with 1,000 masks that are used, and essentially it sterilizes all of them. We put them back into service again, and have been now sort of able to sort of reservice and reuse way over, I think now more than 20,000 masks just as a result, to keep ourselves and our employees safe. The other things is that we, you know, mother is the invention of creativity, or whatever that phrase was. Like we said, hey, we think we need some face shields here. Let's start building them. And so both through community donations, and I think also through, you know, lots of people having their usual parts of their work upended, we had an army of people able to mix our own alcohol, mix our own sanitizer. We actually got teamwork from some of the local bars and sort of rum manufacturers in Durham to make hand wash, and it works really well. And so, you know, same as sort of face shields and all sorts of things that we never thought we would ever be in the business of making. Suddenly you have to sometime. So let's talk about medicines. And I don't want to get into a giant sort of chemistry lesson, because you sure could, but I do want to sort of talk about a few things that have been important sort of steps in the right direction. So the first is a drug called remdesivir. This sort of hit the front of the radar of everyone in March and April. Remdesivir is an antiviral drug. It was originally tried to be used, in fact, because we thought it helped for Ebola. Turned out it wasn't so helpful for Ebola, but in fact, within the context of COVID, it's proved quite useful. And in fact, a large group of centers across the world, which we were able to participate in fact, had 1,000 people balanced. 50% of them would get remdesivir and 50% would not, when they were admitted to the hospital with COVID pneumonia. And in fact, what we were able to show in that group was that if you look in the red box and you look at the time to recovery, what was important there is that on average, people were getting out of the hospital with their pneumonia 4 to 5 days quicker than because they were on that drug. Or in people who are in an intensive care or in sick sort of areas of the higher flows of oxygen, they were getting out 7 or 8 days quicker. And so that may not seem like that much, but to get out of the hospital, to get back to your home, to get back to your family, to start rehab and moving and getting up and around, 4 to 5 days is a big deal. And 4 to 5 days of getting out of the hospital quicker, if you were in New York in the middle of March, would have been a lifesaver for a hospital. So you may remember that at the time, this drug and sort of on graphical representation, what you can see here is, I'll highlight particularly groups C. It's the middle of the left of that screen. So the blue is the drug remdesivir, the pink is if they got the placebo, and the height is how many people recovered. And as you can see, fairly quickly, there's more recovery in the people who received the remdesivir antiviral. So this has really become a standard of care now in all hospitals for people who get admitted. It wasn't specifically trialed in patients who have HIV positive. They're often excluded from trials of these drugs, which we can get into if you want. But importantly, no significant drug interactions with this. So all of our antivirals that we often worry about with lots of different cocktails of medicines don't affect this at all, which is good. This led to another interesting development, which is the idea of a press release suddenly being sufficient to announce a giant change in healthcare policy. And so Tony Fauci, in the middle of May, announced to the world that there was now a new standard of care for COVID. And he did so with only he and a few of us who are investigators knowing the results of the trial. And so the entire community left sort of scratching their head going, boy, I guess you've seen something, but I don't really know. How do I trust this? I think this was the first point where really the sort of sense of the trust of what data we're seeing becoming a real question. And that question has continued to really challenge us, because I think what you've seen, particularly in the United States, but elsewhere as well, has been a real challenge between what we hear in the media, the quality of the data that we see, the message that may be coming out of leadership in government, who often have very different agendas for what their message is, and to try and understand, like, whose data do we even believe in this situation? And I think the idea from Fauci's point of view at the time was to say, look, I want to get ahead of the message. I don't want to be there any confusion on the back end. I don't want people to think, oh, this is just coming out of Trump's White House, therefore I won't believe it. He was seen as an independent person who could say, I have data that says this is the right way to go, you can trust me. And I think actually that worked. The second major study that came out that really has affected the way we treat patients is from a group in the UK. It was called the Recovery Trial. So what Recovery did is that they said, of all of the people who are coming into the United Kingdom hospitals, we're going to give them one of 5 different treatments. They either got a steroid, an HIV drug, Kaletra, Plaquenil or hydroxychloroquine, azithromycin, an antibiotic, or they got none of the above. And they said, right, let's follow these people and see how they do. And in fact, one of the clear-cut advantages was for the patients who got steroids, very specifically a drug called dexamethasone. And for people who were hospitalized and needed oxygen, so they're on the severe end of the spectrum, their survival was notably better when they took dexamethasone. And whilst there were some challenges in this study in terms of how they enrolled, it was such a large study of, as you can see, there's sort of 2,000 people who took dexamethasone versus 4,000 who didn't, very clearly said a survival advantage to steroids. That again, this has become a real standard of care for folks in the hospital. If you're admitted to hospital and you need oxygen, we're going to want to give you now remdesivir and some steroids. Turn the virus off, dampen down the inflammation. Now, steroids are not without their side effects. Dexamethasone is a pretty aggressive steroid. It's the equivalent of taking about 40 milligrams a day of prednisone. And so this messes with people's sugar. This makes people delirious. This complicates infection risk. And yet here, there was seemingly a clear mortality benefit. So at least in the short window of time when we use it for people who are sick, it seems to be very effective. Again, those of you familiar with survival curves, what you can see, particularly down the bottom, for those of you, the patients who are the most sick and on ventilators, the percentage of mortality with dexamethasone, the red line, much less than the mortality in those who did not receive steroids. And so hence, this has really become a standard of care. I mentioned, though, that that trial also included the use of an HIV drug. It included Kaletra. Now, Kaletra is a pretty old drug these days by our standards. There's probably not too many people who remain on it, but plenty of folks who might have had it in the past. And Kaletra was postulated to be a helpful COVID drug because it's what's called a protease inhibitor. And that means that it prevents action of a particular viral enzyme. And that enzyme happens to also be in COVID. Unfortunately, it didn't work. And quite simply, there was no survival advantage at all in people who got Kaletra out of this large British study. And so it's really sort of fallen away off the front line for us now. Similarly, a separate study in Hong Kong tried to look at the same thing, and they said if we were able to compare Kaletra against getting Kaletra and some other antivirals, an interferon shot and a drug called ribavirin, do you do any better? And there was a minimal improvement in terms of viral counts in this viral cocktail, but not so much as to us to think that the Kaletra was doing much. Early on, people grabbed at this because they thought, this is something that we have, it's available, it's in pharmacies, let's use it. In hindsight, it just didn't work. So I want to take a drink break and see if any of you have any questions, and we're going to talk about vaccines.
Some questions came up in the chat.
Yeah, let me have a look. There we go. So 4 questions. Can you be reinfected with COVID? It's the beginning of flu seasons, and so can you tell us about the differences? Yeah, that's a great question. So yes is the simple answer. We already think there is a reinfection rate. And yes, that'll be relevant in the winter. So let me explain that. So when this began, we didn't know how long after you were infected and recovered did your immune defense last. We still don't really know that. We're pretty confident that it lasts for a solid 3 months. But we've only been dealing with this pandemic in the United States for about 6 months. So we haven't had enough time to really follow people through to see how many of those people who got infected in March or April are now getting reinfected again in September, October, or maybe later. Maybe you get a year's worth of good defense. Maybe it's quite variable. So what we tell people these days is you can take really good confidence to say 3 months worth of time after you've recovered, you're probably unlikely to get this again. Beyond that, honestly, we don't know. And that poses some real complications for the flu season because the symptoms that many or most people will get are going to be indistinguishable. I will not be able to look at someone in the clinic or in the emergency room or in the hospital and know whether they have bad flu or bad COVID. And so why that's complicated is that we will want to quarantine people if we think it's COVID. We will want to put them in isolation in a different way if we think it's COVID. We don't want to give those steroid options to people with flu. That's known to be a bad thing. And so we're going to have to sort of test for both, use up more lab resources, spend a lot more time sort of trying to figure out ways around that. And so, like, if there's a plug here to take a flu vaccine right now, it's probably more important this year in order to not have the problem in our community of having both viruses sort of co-circulate. That will be really challenging coming up. Wanda asked a good question here too, which was, are we saying that Fauci jumped the gun with a drug that may have only tentatively worked? In this case, no. I think the reality is that we had the data in front of us that said that it works. We had a lot of people dying at that stage in hospitals, and so we wanted that information to get to people as quickly as possible. And in fact, the whole trial was stopped early by our safety monitoring board, who showed that there was a significant advantage to getting out of hospital quicker. But we also, I think, wanted to control the message and not have it diluted or distorted. And that was the challenge there, is how do you have faith that the message is the right one and yet still get it to people as timely as they needed, when they couldn't sit down and sort of scientifically analyze the paper that was going to be written about it. It was a real challenge. And I think the comment there about still being yeah, it's still a new virus and we are learning. There's a lot of things that I do better at now than what I would have done 6 months ago. You can get retested, Will, for COVID. Particularly in people who get symptomatic again, that'll be something we have to do. So speaking about federal leadership rushing, let's talk about vaccines. So one of the things that I think we've actually done quite well is something called Operation Warp Speed, which is a sort of federal government designed and scientific community sort of executed effort to try and do three things: the development of more medicines and vaccines, improving the manufacturing capacity to make those in a timely enough fashion to be impactful. If you think of a vaccine, we realistically have to manufacture billions of doses. We've never done that before. And then how do you distribute it to people is a third part. So I list only the multiple studies that we're still sort of moving along to try and make it better for folks. But I want to concentrate on the vaccines. So typically vaccines, like any drug, would go through multiple different stages. And those stages are from sort of pre-human studies in monkeys or animals to phase 1 safety studies. Is it safe in certain doses in healthy individuals? Phase 2 studies about whether it actually shows that it's mounting a sufficient immune response like we want it to. And then phase 3, where a few of these vaccines are now up to, which is really an understanding of how it works in a large number of people, sort of tens of thousands of people. And that typically would take 4, 5, 10 years for a good vaccine. We don't have 4 years to wait for this. So this has been accelerated, and often phase 1s overlap with phase 2 and phase 3. And we're already making investments in factories, for example, even though we don't know that the vaccine is going to prove effective, such that we're not waiting with great information that says that it works and no factory that says that we're able to use it. And so this is a crunched timeline, and that is part of the challenge when we then communicate to people that, hey, these actually will be probably safe. But how do you do that in the right way? So we are now up to 9 different vaccines worldwide that are in that last stage of development, phase 3. There are 5 that have limited approval. None of these are in the United States. These are some of the Chinese and Russian vaccines, which are already available for their military use and for other groups. I want to concentrate on the phase 3 that are in the United States, and there's 2 that are all three of these are worth talking about. One called Moderna, a company from Boston. One is a joint effort between Pfizer and a German company. And then a third one is a joint effort between the drug manufacturer AstraZeneca and the University in Oxford in the UK. And these all work in slightly different ways. So there's lots of different designs that we can do for different vaccines. You can either weaken a virus such that it doesn't make you as sick and just inject the virus. We do that, for example, with nasal flu shots, or the measles vaccine does that. You can use a weak virus and put bits of the virus that you actually want people protected against inside it and sort of use it as a Trojan horse. That's what's happening here with some of the adenovirus vaccines. Adenovirus is quite a weak and generally harmless virus that we can insert pieces of COVID into that they themselves don't divide, but they basically use adenovirus as the vehicle to get inside your body. The third one, which we've never done before, is called using an mRNA vaccine. And essentially it's a vaccine that encodes a bunch of the genetics of COVID, or in particular, some of the surface molecules that allow COVID to stick to your respiratory tree, and puts them inside you, and allows your body a chance to respond to those before the actual virus appears. So there's lots of different ways of thinking about this. The key is, though, that we've never had a coronavirus vaccine before, ever, period. We've had them in a few animals and they've not been so effective. And yet here we are. So veterinary world has some experience with this, but we don't in humans. So the kind of things that we're looking to find, firstly, safety data. So, one of the things with a vaccine is we need to show that not only that we understand the kind of symptoms that people get after they have their dose. It is true that almost any vaccine, from flu to shingles to tetanus to anything else, will give you some sore shoulders. These are all injections we're talking about for COVID. Sometimes people get some fatigue, sometimes people get some chills and low-grade fevers. And so how common are they? How predictable are they? How quickly do they occur? And therefore, how can I tell people to say, look, Don't be surprised maybe in the next day or two if you get some symptoms, because that's normal. That's your body recognizing that you've had an immune stimulus and it's defending you. We do, however, want to find more significant reactions. So one of the vaccines that's under trial at the moment was stopped as a pause in the United Kingdom because they had an episode of transverse myelitis. And what that is, it's an inflammatory response in the spinal cord. It's quite significant. We don't know, though, with just one person, if that's because of the vaccine or if that was going to become occurring anyway. What we do know is that that is, in fact, the right situation to stop a trial briefly. It's in fact the exact situation that you want to be seeing as a viewer of these trials, because it tells you they're not trying to rush it. They're trying to look at that data and they're trying to understand if this was related to the vaccine or if it was independent. That's exactly the thing that you want them to be doing. You don't want them to be rushing it. The final thing you want to know is, what does it work? And so what is efficacy? Efficacy in a vaccine against a virus does two things, well, three things actually. Number one, when you're exposed to the vaccine, do you mount a sufficient immune response that looks the same as if you'd actually had COVID? That's number one. And for the most part, the three vaccines that are nearing approval in the United States do that really well. Number two, if you then come in contact with COVID, do you get sick? Are they protective? Do they actually help? For example, we've made plenty of HIV vaccines that didn't do jack when you actually came into contact with HIV. They didn't help, even though in theory they look good. The third thing that's important is, even if you do get protection, how long does that last? Does this become something like flu where we have to repeatedly administer something like a COVID vaccine? Or can it be really strong and last, in fact, for 5 or 10 years like pneumonia or tetanus? We don't know yet. So where this leaves us is that it leaves us with a couple of current things that we can do and a couple of hopes as to where we're headed.
Dr. Wolfe, real quick, before you head into this, we did have a question around the vaccine that I think is an important one to ask.
Yeah, well, let's go back to that.
Yeah, so will this vaccine research be applicable toward an HIV vaccine in the future?
Yeah, okay, good question. Yes, in the sense that we're trying to do something here that we haven't, like there's no COVID vaccine, there's no HIV vaccine. And we are using this as an opportunity to share resources between quite literally hundreds of different vaccine manufacturers to understand how complicated vaccines like mRNA vaccines actually work. They've been theoretical until this point. So whilst COVID and HIV are very different viruses in the way that they affect the immune system, the technology sharing that comes of this is awesome. The manufacturing capability that will come out of this is amazing. The knowledge sharing is really the key there. And yet they're different viruses. So, you know, in some sense, it'll be a 12 to 24 month delay in probably finding an HIV vaccine because so much effort is focused on COVID. But I would say that the sharing of information that comes of that will, in the end, be much more beneficial. That's a really good question. Wanda asked a question about, do we know what these vaccines mean for people living with HIV or hepatitis? And it's a fair question. I think for hepatitis, there's no theoretical reason to think that it would be any different. HIV is a little more challenging because, in fact, some of the patients who are living with HIV have been intentionally excluded from this trial. The argument there is that even if you're doing well with your HIV control, your immune system retains a memory of having seen that. Its immune picture is quite different, having had and controlled HIV. And so when part of my safety measure and effectiveness measure of looking at a vaccine is to understand how it stimulates your immune system, if your immune system is already a little biased in the way that it appears because of its history with HIV, I don't read that the same as what I would read for someone who's negative. That said, so it's harder to understand the way that it responds in HIV. What will be necessary is to say, well, look, if it works really well in HIV negative individuals, as we hope, and then we apply it to individuals who have HIV, even if we can't read the perfect way that it works in their immune system, does it defend them long-term just as effectively as it does for someone who's negative? And that I think we have to find out. But what will be true is that there's a whole separate prioritization list that's being built as to who will need this importantly as a priority. And probably, you know, as you might imagine, top line individuals who get first on that list are in fact like first responders, ambulance drivers, fire brigade, emergency services, ICU folk, you know, people who are on the front line in front of sick patients. Second group will be those who have high risk situations. And so again, if your age or your comorbidities, including HIV, fall you into that bracket, then you'll be fairly high up the pecking order, I think, as vaccine rolls out. There was one other question here that I wanted to just get at. And I think that's got the most of them there. Let me skip forward for one little piece here, and say that, you know, some of the vaccines that we're talking about, in all honesty, are you know, we still need to study them. And for those of you on this call who may not be able to join these studies because of your HIV status, that doesn't mean you can't lobby a lot of other people around you to say, hey, you know, we need people to volunteer to be a part of these trials. And we're not going to get to the answer that we need at the pace that we need unless we have people volunteering. And I would say that the history is rich in the HIV community over the last 30 years of volunteerism in a way that is really unique, lobbying in a way that is unique, and sort of being quite influential. And I would say that the opportunity to do that here is also pretty unique. And so even if there are immunologic reasons not to be a part of the first early trials, that doesn't mean you can't go and convince a whole lot of other people to also participate, because I think we need folks to be willing to do that. And I'll end with just one extra piece here. If you were to ask me initially, what do we have as options now for COVID? We don't have a lot before you make the hospital. I can tell you here to stay away from other people and wear a mask. And that's kind of it. In the hospital, if you're mildly sick or quite severely sick, we do now know that there's an antiviral and a steroid that can help you recover, but not everyone does. This is still causing death in people who land in hospitals, even with good treatment. I will give you some guidance that one of the things that is now particularly thought about, and this probably did grow out of the HIV world, is the concept of PEP and PrEP. You know, these are common conversations in HIV literature, but they're not common in other environments. And yet, post-exposure prophylaxis here, if I know I've had contact with someone who's got COVID and I've had a breach in my protective equipment, or I'm quarantined in the house with someone who's positive because they're in my family, can I take an antiviral medicine that would be protective? And in fact, there's actually research that Duke is underway at the moment to try and do just that. The alternative is maybe I know I'm a high-risk individual for exposure. Perhaps I work in an intensive care. And so in that situation, one of the other trials that's still going on is it worth me taking a daily antiviral as a protective event, knowing that I've got a higher risk of being exposed, at least until a suitable vaccine becomes available. And again, I think we've learned a lot from our experience with PEP and PrEP in the HIV world that guides our faith to believe that that should be able to work. We haven't proven it yet, but I think there's good hope that that will come to pass. So I can see there's 3 more things in the chat. Yeah, so for folks who want, I should maybe try and leave some details here about how to try and get involved. There's a couple of different vaccine trials that are now open, both at Duke and UNC, and also one out in Wake County. to sort of look at phase 3. So we know they're safe, we know they work, but now we've got to try them on large numbers of people who might be willing to sign up. So perhaps after this, I can leave some of those contact details with different folks, and you know, for folks who want to volunteer, it's not for me to pressure you into it in public, but I can still give you a little jab in the ribs to say, you know, think about it, it's worthwhile. And so I will end there and say that, you know, one of the things that's true, and I think we now sort of realize this, is that this is not going away. You know, we can have leaders who get up in front of us and bleat that this is just going to go away. It's not. You know, we can have plenty of people who feel like we can open up our community and go back to what it was like in 2018 or 2019. We can't. And we've got a long way to go. And yet I would say that with really simple things, we've in fact shown that, you know, really simple things actually work. One of the great things that came out of this in the Southern Hemisphere was that by simple distancing and masking, they almost had no flu season. You know, fancy that. There's thousands of deaths every year due to influenza. They almost saw none because people were doing the things to prevent COVID, and they are exactly the same things to prevent flu, distancing and masking. So there will be good things that come out of this, but we can't expect that the next couple of months are just magically going to go back to the way we used to be. It's not going to be the case for a while. And I think that part of our energy here needs to be directed towards honestly just focusing people to keep pushing on and not get fatigued, you know, to expect that wearing a mask is going to be something that we're all going to have to do for many more months to come. And that's okay. So I will stop there in the interest of having as many questions as you all need. And if I can stop my share.
So I think that Angela Vick-Lewis raised a good question around, can you explain kind of what we're seeing around the effects of race and COVID-19 and the impact it's having?
Yeah, wonderful question. So yeah, there's a bit of history to that too. So early on, I think what was felt initially is that there must have been something that was uniquely significant about African-American history or genetics or something about sort of African-Americans and their way that they immunologically dealt with COVID that was different. I think what makes much more sense now is that that's probably far less to do with genetics and everything to do, or a vast majority to do with socioeconomic situations. And we've seen that as this illness has then ripped through our Latino community in the same pace. And so we've seen that as it's hit hard in our long-term care facilities. You know, it's not been so much a race or ethnic or issue as much as a social separative issue. So if your community is disproportionately affected by poor health inequities, this is going to be more significant. If you have higher proportions in your community of diabetes or heart disease, this is going to be more significant. If you're in a long-term care facility where you haven't had the financial structure to put in good infection control practices within that setting, this hits those nursing facilities harder. So in some ways, I think the answer to that question is that this has shone an awfully bright light on the social inequities that we have in our community in general, rather than this being something that is particularly unique to any one particular race or community or cultural group. And then it's on us to see how we respond to that. Prisons is another thing. This went belly up in some of the prisons around here. Butner had an enormous outbreak. And again, you know, how do we as a community want to respond to that? Do we want to respond by going, great, it's all done, let's go back to what we used to do? Or do we want to respond by trying to change the way we manage our prison systems? You know, maybe there is actually an opportunity here. I hope that wasn't too political an answer for you. I don't think it's genetics. I think the genetics is the soft way out of thinking about it. Not to say we shouldn't think of genetics. There may be a part of it that's true. I think the bigger part is social and health inequities playing a big role.
Dr. Wolf,
And
I
then
have a
Wanda had
question.
asked a question. Yeah, Rita.
I don't know if you saw my comment, but being the antivirals are being used, the older ones, and for long-term survivors, will your body recognize that, hey, I've had this medicine before, and make the vaccine less effective?
No, I don't think so. So the I think the main part with the vaccine is really how robust is your immune system response on a good day to anything. So if you're sitting with a T cell count of 1,000 and you have a viral load that's been controlled for years and your immune system is healthy, you should respond to the vaccine in almost the same way as anyone else. If you're coming at the vaccine from a position of a CD4 count that's 50 or 100, then I think it's a different question. And in that setting, we don't know. And I would presume that your ability to mount a good immune response would actually be less. That said, your ability to handle COVID is probably poorer in that situation also. So probably, again, more reason to want to go ahead and put those people into a vaccine group early on. But I don't think the medicine should play a part in that, Rita, and answer the question. It's a good one.
I have a question, Dr. Wolf.
Yeah.
My viral load is detectable, but
Terrific.
for whatever reasons, my CD4 has never exceeded 230. How would you, I guess I should stay in the house, washing my hands, mask. Just your thoughts.
Yeah, it's a good
Thank
question. It's a good question. So I think there's a lot of people who fall into that category, isn't there? When maybe your T cell count, we see that a lot in people whose T cell count was low initially and sort of recovers enough, but doesn't really get up into what we would call a normal range. I guess there's two questions to that. Number one is sometimes if people look at their CD4 percentage in that case, it's actually much healthier than their actual absolute number. And so that could be something you could ask your clinician to say, look, can you help interpret that to me in a way that may give us sometimes a more accurate reading of truly how strong your immunity is. I think the other thing to say is we've looked over the decades at cohorts of people who fall into just that group, whose immune system as measured by a CD4 count never quite got better than 200 or 300. And they don't seem to get sick with any greater frequency than folks who have a completely normal looking CD4 count. So I think there's two things that are clearly at play with HIV control and HIV risk. One is your CD4 count, and the second is what your viral load's doing. Let me paint you a picture as to why that's important. I could take two people who have a T cell count of, let's say, 100, one of whom has never been on meds, the other who's been on meds and has an undetectable viral load. The undetectable person will get far fewer infections, even though the T cell count on the surface is the same. So you told me one thing which is really crucial, that your viral load's controlled. And I think that is actually arguably more important than a T cell count of 250 or 300. And that's a credit to you, let's be honest. Now that doesn't mean there may not be other comorbidities that lead to risk. And so I think, like I said at the beginning, that South African group, they showed that, age, diabetes, weight, cardiovascular comorbidities are all part of this, probably more so than someone's HIV control. Asthma, someone had said that. Yeah, absolutely. Yeah, so any airways disease makes it more likely. I think someone had said earlier, thank you for your comment about not going away easily. I think that's the reality. We shouldn't sort of kid ourselves with easy sort of stump speech that plenty of people give to say, we're going to fix COVID. Like, we've been trying to fix it for 6 months and it's still here. It's still pretty happy and it's still going to continue to be here. So don't believe the BS otherwise. I think I've answered most of the questions.
Yep, it looks like everything from the chat was answered, and I know that we are getting right up on 11 o'clock, so I want to be cognizant of everyone's time and appreciative of yours as well. But we will be sending out a follow-up email with the link to this once this is up on YouTube. And Dr. Wolfe, if you have any resources that you would like to share with folks, feel free to send those to me and we'll send them out to the group. And then folks can respond to me with any questions and I'd be happy to send those your way just to get any further clarification if things come up later. But certainly really appreciate your time and this wealth of information. I think it's really important as we continue to move forward. It's been a while since we've revisited just what COVID-19 currently looks like. I think it was closer to the start of the pandemic. And I know a lot has changed. It's still scary, still rampant, but 6 months later, a lot has changed and a lot of knowledge has been gathered. So super appreciative of your time and for sharing all of this with us, and look forward to hopefully working with you again soon to maybe updates in the future as things move forward.
Well, I appreciate you putting this on. It's an important topic. And I mean, I think if I want to leave people with one comment, it's, you know, I sort of lobbied hard for continued thoughts about distancing and masking. But I think the other things that we've had victories on is if you feel sick, pop your hand up and ask to get a test. Testing is now, it is widely available. And any one of you who have connections to an HIV clinic or, you know, through a primary care physician can certainly tee that up really easily these days with quick turnaround. It makes, even if it doesn't make as much difference to you, it makes a huge difference for the people around you. You know, I think if there's an opportunity for a flu shot, please consider taking it, and have good faith that I think there's, despite the politics on the very top, there's a hell of a lot of smart people thinking about vaccine science on the back end. And I was super reassured to hear the CEOs of all of the main vaccine companies saying, we're not even going to put our vaccine forward for consideration until we feel that we're doing you a good job from a safety point of view. And that's the right message for them to say, not only clearly from a medical point of view, but frankly from a business point of view. Like if they put forward something that's not safe and they get caught with their pants down, they're in worse trouble than if they weren't even in this industry. So have faith that I think when it's ready, it'll have gone through some very thorough checks.
Awesome. Well, again, thank you so much. Thanks everyone for joining us today. Look out for an email later on today with this link with some resources. And we will have another webinar tomorrow morning at 10 a.m. with the folks from Steady Collective to talk about some harm reduction and HIV intersections. So look out for that. Y'all have a wonderful rest of your Wednesday and we will see you all soon. Bye, everyone.